A very warm welcome, everyone. I, Dr. Ritika Dhiman, on behalf of Voice of Healthcare, welcomes all the speakers and the viewers who have joined in for today's discussion. Voice of Healthcare, along with our supporting partner, Novo Nordisk, has taken an initiative to bring together the experts and speakers for today's session on management of postpartum hemorrhage, associated risk factors, and treatment. Postpartum hemorrhage is one of the leading causes of maternal morbidity and mortality globally. It is a significant and potential life threatening complication that can occur after childbirth. Today, we have brought together a panel of experts who will share their insights and experiences on the risk factor associated with postpartum hemorrhage and the most effective treatment options available. We hope that by the end of this discussion, we will have a deeper understanding of this critical issue and be better equipped to address it. So, without further ado, let's get started with our esteemed panelist. I welcome Dr. Mala Srivastava, Senior Consultant, Obstetrics and Gynaecology, Sir Gangaram Hospital, Delhi. Welcome, Dr. Mala. Dr. Deepa Dewan, Director and Head of Unit, Obstetrics and Gynaecology, Max Hospital, Gurugram. She will join us in a bit. Dr. Asha Dalal, Director, Obstetrics and Gynaecology, Sir H. N. Reliance Foundation Hospital, Mumbai. Welcome, Dr. Dalal.
Thank you.
Dr. Astha Dayal, Senior Consultant, Obstetrics and Gynaecology, CK Birla Hospital, Gurugram. Welcome, Dr. Dayal.
Thank you.
Along with sharing her views, Dr. Astha will also be moderating this session for us today. Over to you, Dr. Astha.
Thank you, Dr. Ritika, for introducing all of us, and welcome all of you to the session. So today, as you all know, we are going to talk about something which is, I think, every gynecologist's nightmare and something that we all dread. And more than that, it is actually one of the biggest challenges which we are facing as a developing country, because maternal mortality is most commonly caused by postpartum hemorrhage or bleeding after delivery, and about 38% of the maternal deaths are because of postpartum hemorrhage. So this is actually the most leading cause of maternal mortality. And in India, we have a big example. If you all know, the Taj Mahal was constructed for Mumtaz Mahal, who died during childbirth because of postpartum hemorrhage. And unfortunately, 99% of these deaths are happening in developing countries. So that means it is so preventable that the developed world is only having 1% maternal deaths. And in Europe, so maternal mortality as such is a marker for the healthcare efficiency of a country. So every mother has the right to live, and no mother should die during childbirth. And this is such an important discussion we're going to have today about postpartum hemorrhage. And we have a very esteemed panel, and I will be starting with my questions with Dr. Mala initially. So, ma'am, welcome first. And what exactly is postpartum hemorrhage, and what are some of the common causes and risk factors associated with this complication?
Thanks, Dr. Astha, for having me here, and Dr. Deepa, making me a part of this program. Postpartum hemorrhage is defined as bleeding from or inside the genital tract after delivery of the baby. The amount is such that it threatens the health of the mother. Any blood loss more than 500 ml in vaginal delivery or more than 1000 ml in cesarean section is called PPH. Of course, we see that our mothers are mostly anemic. So any amount of blood loss which threatens the health of the mother is considered as PPH. Now, what do you want to know? What are the risk factors for PPH? The risk factors for PPH, the causes, as we all know, the commonest cause is atonic PPH, traumatic PPH, there can be tears, partially retained placenta and fragments of products of conception. There can be coagulation disorder. And of course, one of the causes which is rising nowadays is placenta accreta or placenta previa. The risk factors or the predisposing factors for atonic PPH are over-distended uterus, that is multiple pregnancy, polyhydramnios or macrosomalia. Then grand multipara, thyroid, third child, fourth child, fifth child, anemia and malnutrition, which is very common in our country, prolonged labor and precipitate labor. APH, if the patient is already having APH, then she is a candidate for PPH as well. If we use induction of labor or augmentation of labor and the patient is prolonged labor, these candidates are also candidates for PPH. If there are uterine fibroids or if there is a prior history of atonic PPH, then again they are the candidates for PPH. If you are using anesthesia or mismanaged third stage of labor or they are chorioamnitis, then also there is a chance of PPH for these patients. Sometimes when we are delivering instrumental delivery, delivery through undilated cervix, like we are giving vacuum delivery or forceps delivery or instrumental delivery, or there is occipital posterior position, and there is a traumatic vaginal delivery, there is chances of so much trauma to the birth canal, trauma to the cervix, trauma to the vagina, and there is vaginal trauma, multiple tears. All this can also lead to PPH, and this leads to traumatic PPH. So there are so many causes of PPH, as we all know. And once you have a patient of high risk factors, then in that case, you have to be very careful, use some preventable measures to prevent PPH in these conditions.
Sure. Thank you so much, Dr. Mala. I think you've mentioned all possible causes and all the risk factors for PPH. I now welcome Dr. Deepa, and ma'am, we also want to ask you the next question. So, as we all know that PPH is a big cause of maternal mortality, and not just mortality, there is a lot of morbidity because of blood loss, and this affects the health of the mother, and it has a major impact. The health of the mother or the life of the mother has a big impact on the health of the family also. So, I would like you to throw some light on what are the long-term consequences of postpartum hemorrhage, both for the mother and for the newborn, and how can these be prevented or managed?
Yeah, hi Astha. Thank you for inviting me for the session, and I am very happy to be part of this panel. Yeah, so as far as your question goes, since postpartum hemorrhage involves major blood loss for the mother, so there are of course long-term consequences that can come in because of that hemorrhage that she's going through. The patient is having so much of hemorrhage, she's of course going to present with some immediate signs of hemorrhage, which can be hemorrhagic shock, and then the consequences of that, and then the treatment factors. So in case we are treating the hemorrhage, whether we've been able to treat it medically or we've been having to take a surgical step to do the treatment, also depends on how the mother will respond. So there can be consequences wherein we have done a uterine artery ligation, or we've done an internal iliac ligation, or having to go up to the stage of a hysterectomy in such a case where there has been a postpartum hemorrhage. So that's a long-term consequence that one can talk about. And a hemorrhage leading to hemorrhagic shock, the mother, kind of ending up into the ICU, and even death for that matter, in a case which is not managed very well or could not be managed very well. So a preparedness for postpartum hemorrhage is very, very important. We do see cases of DIC when the mother has gone into postpartum hemorrhage. So all those things do come up in these cases. Plus for the baby, so if the mother has had a hemorrhage where there's been a lot of blood loss, there could be a Sheehan syndrome. So the baby could be deprived of a lactation. So all those complications can come in as a long-term complication. So being prepared for postpartum hemorrhage gets very, very important here.
Thank you, ma'am. So as you rightly said, we need to be prepared for all the for managing a postpartum hemorrhage, and that's where my next question comes to Dr. Asha. So as we all know that in institutional setups, we are a lot more prepared, but generally what all precautions or what all key signs and symptoms should healthcare providers be aware of to diagnose and manage the postpartum hemorrhage?
technically, postpartum hemorrhage is when the blood loss is more than 500 ml in a normal delivery or 1000 ml in a cesarean. But practically, all of us know that when you are finding the blood loss is happening more than what it generally should, it should alarm you. The problem is never in a high risk case because we are prepared. The problem is in a case who is bleeding, trickling little by little, and not really at a time. So, if you find that there is a blood loss which is unexpected or more than what you expect, most of us, that is a red signal. Start thinking about postpartum hemorrhage. Whatever medication you are using, you will start following your protocol. If it has not already been done, better send the blood for cross matching and see to it that it is available before it becomes too much. If you find that this is happening, look for signs of a tear or something which you have not done before. Touch the uterus. Most of the times, it may not be completely atonic, but it may be contracting and relaxing in between. Patient initially may not have tachycardia, may not have a hypotension, but if you do find that slightly there is a rise in the pulse or something like that, that is another sign that you know that there is something that you need to arrest before it reaches a stage where it becomes unmanageable. I think you want me to talk about the initial management also.
Yes, ma'am. I think my
So
next
as
question
far,
will cover that. Yeah.
so as far as the initial management is concerned, it depends on two things, whether it is atonic, whether it is traumatic. Mostly, coagulopathy is the third thing. But whatever the thing, first thing is to have an IV access, start with crystalloids, shift to blood as fast as possible. Now, where it is traumatic, you need to identify the cause of the bleeding and repair it. Whether it is a laceration which is not seen, cervical tears, uterine tears, identify and deal with it. It can be a uterine rupture, it can be a partial rupture, whatever. If it is atonic, all of us have a protocol. Initially, there is the medicine where we either give pitocin or carbetocin to start with. Then there is methogen. Then there is carboprost. Then there is misoprost. People have their own protocol how they go about it. But this is the stepping up of the uterotonics. Besides this, if the uterine massage, balloon tamponade, where you can use a balloon to temporarily stop the bleeding, it's easier if it is an open abdomen for surgical methods. Then you have stepwise devascularization where you can do a uterine artery tying, ovarian vessel ligation, Beeline sutures or compression sutures, whichever you are used to. And then, of course, you have internal iliac ligation. Hysterectomy should be the last resort. Of course,
True,
if you
ma'am.
have the facility, uterine artery embolization is also a very good option. Even temporary ballooning of the uterine or internal iliac works wonderfully in settings where that is possible. Sometimes a packing is done. Sometimes you may have to transfer a patient. So there you can have some pneumatic, compression gown where you have time. But the most important thing is don't be a hero. Don't try and do it all yourself. Immediately, you have to have your team available. Inform the blood bank because blood products are very important. Inform the anesthetist because for massive transfusion, you have to have a massive transfusion protocol. The electrolytes, the blood gases, the potassium levels, the calcium levels have to be monitored, and you have to look for coagulation profile because if it is a coagulation problem you are expecting it, then in that case you need to have the blood products ready, whether it is whole rbcs, whether it is pack cell platelets, or whether it is a cryoprecipitate. So these are some of the initial management steps that you will do as soon as you know. Most important being the team approach, call for help. Believe me, half your problem is solved if you have a good anesthetist and you have a good competent person to assist you to do whatever you need to do.
Thank you, ma'am. I think you've summarized the entire management of postpartum hemorrhage very in such precise and comprehensive manner. My next question is also related to this. So I'd like to ask Dr. Mala that sometimes in a very fast-paced and a stressful clinical setting, we do end up with a patient with PPH. So, what are the immediate interventions that can be taken to manage this, and how can we prioritize these interventions? Like, what should be a part of our PPH drill so that we are always prepared for managing a PPH?
See, basically, just as Dr. Asha said, that we face problems in low risk patients. For high risk patients, we are already very much prepared. If we have a case of placenta previa, we have a case of placenta accreta, we know that these patients are candidates for PPH, so we are prepared. We plan our surgeries during daytime with a lot of team, with our uh, blood bank ready, with our colleagues ready, urologist if necessary, then vascular surgeons if necessary, interventional radiologist if necessary. But when problem occurs in a low risk patients, primary gravidas or second gravidas, when we are not expecting PPH in these patients, that is how where we are taken aback. So how do we prevent PPH? We have to think that each and every patient, antenatal patient who is coming to us, is a candidate for PPH. So we have to have a regular antenatal checkups. We must ensure that their hemoglobin is at least 11, if not 12. So correction of anemia during the antenatal period is very important. And of course, we have to identify high risk factors. That's of course. And if possible, we have to have regular drills of PPH done in our labor room settings. And we should have, whenever a patient walks in a labor room, we always cross match the blood. We do not, we take a sample for cross matching, and we alert our blood bank that this particular, keep this blood, particularly this blood group ready in because our patient is in the labor room. We may not release the blood, but we keep it cross matched. That makes a facility alert. Secondly, whenever we need blood, we get the blood within 20 minutes. Our blood bank is already alerted and they have kept aside the blood, and they just quickly cross match and give it us within 20 minutes. And of course, whenever a patient is in labor, we always try to maintain a IV access. Though we may or may not give any fluid through that, or syntocinon or pitocin, anything, we just make an IV line access ready for all our laboring patients. So these are the preparedness that we have. We uh, we optimize the health of our all antenatal patients, but every case may not be so lucky. We do get patients as a casualty, as an emergency to deliver, and these patients may not be optimized as to our standards. So what do we do? As soon as that madam said that we should not wait for 500 ml blood loss in vaginal delivery, we can anticipate that this patient is having more bleeding than the others, so we have to catheterize the patient. Massage is controversial. Some people say that massage is good. Some say that uterine massage does no good. You have to use your carbetocin or pitocin. Active management of third stage of labor is a good armamentarium in preventing PPH. And most of the time, the PPH is prevented if we advocate active management of third stage of labor in all our patients. Secondly, then if the PPH is still occurring, we have to start syntocinon drip. Normally nowadays nobody is giving methergin. Pitocin has to be given, mesoprost has to be used, carboprost has to be used judicially and stepwise, as Dr. Asha said. If and simultaneously you have to keep exploring and looking for any tears. because if there is a tear, traumatic PPH, it has to be repaired. No amount of blood blood replacement, no amount of IV fluids is going to treat the tear that is already occurred. You have to diagnose if there is a patient is having uterine rupture. This decision has to be taken. Not necessarily uterine rupture will occur in the previous cesarean patients. Sometimes uterine rupture can also occur in previous normal deliveries, previous DNC patients, previous history of perforations also. So here you have to have a close suspicion. If there is no traumatic PPH, the amount uterus is hard, still sometimes you have to keep a very low risk of threshold for suspicion of all the possibilities of PPH. And if you are having a vaginal delivery, then there are so many methods that they say pallies, clamps, and all this. But actually, your uterotonics do wonders. Mesoprost 1000 ml kept rectally, carboprost given every 15 minutes. You can give up to 6 doses. Methogen, it's controversial. Nobody uses it. But once upon time, methogen was used. Syntocinon, you can give 20 units in, or in 500 ml, 30 units in 500 ml. All this mostly works. But in case it doesn't work, then in that case, you have to assort to either uterine packing, balloon, uterine balloon. All this also helps. If there is a, suppose the PPH is occurring during cesarean section and abdomen is already open, then in that case, as madam said, stepwise uterine devascularization does work, internal iliac ligation does work. And normally when these patients are having secondary PPH, that at the time of delivery there was no PPH, within after 24 hours or after 2 days or 3 days they are having PPH. In that case, sometimes uterine artery embolization can be used as a method of controlling PPH. So these are the modalities that we use, and of course hysterectomy should be the last resort. But in case you have to do hysterectomy to save the life of the mother, please do not hesitate. Because if you are taking a later decision, then already a lot of blood loss has occurred. Patient may go into irreversible shock, and you may not have the chance to save the baby, save the mother. So, anticipation of the problem, quick action, support system of your colleagues. Don't hesitate to call your senior colleague, because a person who is coming fresh will have better ideas and you'll have better support to treat with the case of PPH. Texit or tranexamic acid can also be used nowadays as a method to control PPH, and it has been now added in the armamentarium of the drugs to use in PPH. PPH continues to be a nightmare, so you have to be very much careful about dealing with all the patients, especially low risk patients when you're dealing with. Then you have to be very careful about PPH. Because when you have a patient of placenta accreta, you are prepared. You counsel the patient that it's the case of placenta percreta or accreta, we may not be able to save the uterus. That consent you have already taken before patient has gone into labor or patient is coming during the antenatal period. And if you have a case of placenta percreta or accreta, kindly do not try to save the uterus. Do the hysterectomy as soon as possible. It is a clamp, cut, and drop method. Within 20 minutes, you'll be able to do the hysterectomy and you'll be able to save the mother. Otherwise, what happens if you're taking a late decisions? You need to transfuse almost 17 units, 18 units of blood, other FFPs, PRPs, all blood and blood products. All this adds to the morbidity of the health of the mother. But if you take a quick decision for hysterectomy, at least you can save your mother from the morbidities of massive blood transfusion, and later on the recovery is better. If there is a less blood loss, less blood transfusion, it adds to the health of the mother in the long run.
Thank you, ma'am. I think you explained very well how we should manage every laboring patient in a hospital, and how even for low risk patients, blood should always be arranged, the IV should always be in place, active management of the third stage. So, being prepared for every patient, and so that we are not caught off guard, and then having the presence of mind and making a quick decision for hysterectomy, although it's a difficult decision, but it can be life saving. So very rightly said, ma'am. But coming to patients who are, so as we've seen that most of the PPH and maternal mortalities, they happen more in rural setups or in the lower socioeconomic groups, because probably they don't get access to the kind of care that we are giving. So my next question to Dr. Deepa would be, so what role can antenatal care play in identifying women who are high risk for PPH, and so that they can be referred timely, and what are some of the key strategies for preventing this complication in the first place in the antenatal period?
So, like Dr. Mala very correctly said, that it's this low risk patients which always land us into trouble when we come to PPH. When we are prepared, we know that this is a particular high risk patient. How do we identify a high risk patient? A high risk patient would be somebody who has an over distended uterus. We know somebody who has multiple gestation, who has polyhydramnios. So there are more chances that such a patient would have or could have PPH. So we are prepared for it. We know that as soon as the baby is born, the syntocinon has to be started. We know that we have to be ready with blood and blood products with us. We know that these patients can have more chances. There could be a patient who's into prolonged labor. So somebody who's had a long labor, we've used a lot of syntocinon, she's been in second stage for a long time, or she's been in a latent phase for a long time. These could be patients who are more prone to have PPH, and again, we are prepared. We know that, as soon as the baby is out, we know we've given the instructions to the staff nurse to start the syntocinon and, follow the drill of PPH. Problem happens when we are not prepared. Again, we would be prepared for somebody who's, we know we've done a difficult vaginal delivery. So we've applied a vacuum, we've applied a forceps. We know that this is a patient which could have a traumatic PPH, or she could even have a atonic PPH. 70% of PPH that happens is atonic. So we are kind of aware of all this. We know we have a patient who has anemia, has more chances that she would have PPH because her oxygen carrying capacity is low. She would have more chances that she would have an atonic uterus and then subsequently land up into problems or complications of PPH. So one is that we can identify these risk factors. We have a patient who has a coagulopathy. We have a patient who has a low platelet count. We know that these patients can have higher chances. Or somebody who has, like Dr. Mala said, somebody who has a percreta or a creta, we are prepared. Somebody who has fibroids in her uterus, again, we are prepared that, yes, this is a patient who can have problems. But then how can we prevent it in patients whom we are otherwise take, like you said, in rural setups? Probably the patient doesn't have a diagnosis. They don't know that she has a fibroid. And there can be chances that this particular patient might just land up into PPH just because her uterus is not contracting well or is more vascular because of the fibroids being there. So a very important thing here, whether it's in the rural setup or it's in an urban setup where we have all the facilities available, is to have a patient during her antenatal care to have a good hemoglobin level. That is a easily done up thing which can be done anywhere, whether it's in the bigger setups, it's a tertiary care, or it's a primary care setup. A good hemoglobin is something that we should be targeting in all our antenatals. This would really help us. So if we have a patient who's well taken care of in her antenatal period, has been eating well, taking her iron supplements, has monitored her hemoglobin, if not, at least she's been taking her supplements and is eating well and taking a good nutrition, her hemoglobin is good, her chances of having PPH would be definitely reduced. One is to prevent by keeping the hemoglobin well. Two is to detect a high risk patient by checking her previous records when she comes in for her delivery. Three, if you have a patient in whom you're suspecting that she would probably have PPH, to be completely prepared, like we just talked about, having blood and blood products ready, to have a backup ready, to to have a team of obstetricians and anesthetists ready so that in case there is trouble, we are there, we can jump in and just save the mother's life. To have our nursing team ready, that is also important. So they should be trained on the PPH drill. They should know how they have to go about it. They should know what drugs should be available next to the patient at the time of delivery. So those are things that we can target to prevent PPH and its morbidity and mortality. So one is to have a good hemoglobin during antenatal care. Second is to identify the risk factors. Third is to be prepared at the time of labor that yes, this is a patient who might need these supplements or these interventions, and be prepared for it. Thirdly, fourthly, of course, like Dr. Mala very correctly said, is to call for help. So once you identify that your patient has bled, okay, so the assessment of blood loss is not always very accurate. You might just have a trickle and you realize that patient has already bled, maybe already 500 ml is your estimation. But yes, it might be somewhere near 1,000 also. So to be prepared, yes, this is a patient which is bleeding more than I would have expected her to. I should have people around me ready to give me support on that conjuncture, that if this patient lands up with a heavier bleed, we are prepared to have the blood and blood products in and to have save her life. So these are the things that I would suggest should be there for anybody who is going into labor, and be prepared for what is not expected is what PPH is. To be prepared and to save a mother's life when we are not expecting PPH.
True, ma'am. Thank you so much. So, I think all of you have at some point mentioned the importance of teamwork and of communication and having a good team. So, I would like my next question to Dr. Asha, ma'am. Could you please throw some light on how healthcare providers work together with other members of our care team, like midwives, obstetricians, anesthesiologists, so that we ensure that postpartum hemorrhage is promptly diagnosed and managed in a coordinated and collaborative manner?
As you very rightly said, Astha, most of these problems, they occur anywhere, but in a rural setting or not in a tertiary care. Most of us over here have a place where everything is available. The problem arises where there is no blood facilities, where there are no experts, where there is not a team. So it will help a lot if every institute or every small place also, the people over there, they know where to get blood from, how to transport a person. Very often it used to happen that a person who is bleeding in a small place, they used to go to 10 hospitals before reaching somewhere. So if you already have identified a place that a hospital is associated with this tertiary care hospital, it becomes very easy. And when you're talking about a team, you see where the government has helped, at least in Maharashtra, 104 you dial blood is available. 108 ambulances are there to transport a woman to a tertiary care center. If you have a team where you can say, trans if a transfer somewhere, then that becomes easier. Now, coming to your own team, I cannot emphasize the importance of drill. Once in 3 months, we always have a drill for various obstetric emergencies, including PPH. The drill is not only about which drug you will use when, but it is also about who is responsible, who will take the IV access, who will call the anesthetist, who is the person responsible for monitoring the blood loss, arranging that blood comes, which blood product comes, how are you sending your investigations, and who's monitoring the reports. As important it is to have what we call a PPH kit in labor. Now, this PPH kit includes everything that you will need, from an IV access to sponges to speculums to drugs to catheters, emergency anesthesia drugs. This will include suture materials, also things which you need to stop localized hemorrhages. So you see to it that this kit is there in every labor room and in every labor OT. Besides this, you should be trained. How are you going to do? It's very important to have charts or your protocols put up in the labor room, that this is the pathway, this is our SOP for our institute for managing a postpartum hemorrhage. So nobody is talking at cross purposes. It does not have to have Asha, Dalal, or a Mala, anybody to say what is to be done. Your basic person also knows this is the protocol, this is the person to contact. And if there is a PPH, you know who is your team, you do. Now, it is important for us to have this team. It may be possible in your institute. It may be possible for you to tie up with some institute. But you must have this team. Your team must include somebody who can do an internal iliac ligation, somebody who can help us with our blood and blood products. It's not an easy thing managing placenta, percretas, accretas. Even if you do for these hysterectomies, if you can offer a placenta previa, many times we arrange for a pre-operative uterine artery ballooning. If it is not required, you don't do anything, but the balloons are kept in place. We are lucky to have a hybrid OT. Do the hysterectomy. If it is not bleeding, remove the balloons after a few hours. If it is bleeding, do the embolization. But in spite of that, there are many patients who need not only blood products, but they need ICU management for all the long-term problems. Patient has bled. She may go into consumptive coagulopathy. You need to be able to manage that also. So you have to be familiar with the massive blood transfusion protocol. Your blood bank has to be capable of giving this to you within 15-20 minutes. Now, this is where it is important that if you cannot do it in your place, shift the patient as fast as possible. Do not even use 15 minutes. Very useful. Don't deal with the midwife or the nurse when the problem occurs. If you have every few monthly, when they change, when the trainings change, when you get new residents, when you get new clinical assistants, if you go on and on, it is not something which is done once. It has to happen on a regular basis. And the minute something is taken out from your PPH kit, it has to be replenished stat. You cannot say that, okay, it is done today, I will replenish. It is not, there is no rule which says you've had one PPH case just now. It will not happen 24 hours from now or in the next. We hope not, we pray not. But see, always be prepared. It's a Boy Scouts motto and it should be ours also. So, kits, drills, and a team effort definitely goes a long way. And by the team, I include everybody from your runner boy to your blood bank team to the team in the pathology. Each and every one plays a very, very important role in saving that patient. It can, most of the times we are lucky in not requiring many things because we have things in place. But everybody and every time we are not that lucky. Even if you have massive blood loss, if you have a protocol in place, if you are capable of managing everything from an simple suturing in deep phonesis to managing rupture uterus to hysterectomy, I'm sure that it will go a long way in reducing not only the mortality but even the morbidity and long term consequences, which are definitely associated with the postpartum hemorrhage.
True, ma'am. Thank you so much. I think very rightly and very effectively told us, ma'am, that it is so important because as obstetricians, I think since our training, we know what our part is. It's drilled in our head. But to make others do their part, that is the part. That is the thing that will actually lead to an effective management of PPH. So now coming to another very, very important part. So like we know what we have to do and we will always do it in the best interest of the patient. But what about patient counseling? So Dr. Mala, I will like to ask you about how can healthcare providers work with patients and their families to ensure that they are fully informed about the risks and the potential complications associated with childbirth, including PPH.
See, basically, when we are obstetrician, we get an opportunity to meet the patient and the family throughout the antenatal period at least 8 to 9 times, if not more. So we have to counsel the patients that even a low risk, because the patients are very worried. हमारी normal delivery तो हो जाएगी ना. So we have to counsel that most of the time, even we want natural birth. We do not want to interfere with the natural process because pregnancy and delivery is a natural process. But we only intervene when it is necessary. We do not do unnecessary inductions. We do not do unnecessary interventions. If it is required, then and then only we go for augmentation of the labor, because being a natural process, interference or interventions that also promote complications in our low risk patients. So we have to use our facilities in a very intelligent way, not to interfere with the natural process, not to do interventions unnecessarily. But of course, if the medical condition demands, we do induce labor, we do augmentation of labor, we do instrumental deliveries, but then they has to be done in a very professional manner and in a safe environment. So all that counseling has to go in the antenatal period. If we have a patient of multiple pregnancy, then we counsel this patient that you are into a high risk pregnancy and you should deliver in a tertiary care center with all the facilities for emergency cesarean section, blood bank facilities, and other supportive system departments as well. If we have a case of polyhydramnios or large baby, gestational diabetes, all these patients, if we encounter during the antenatal period, we guide them, we tell them that these are the possibilities that can occur to you, and that it's better that you deliver in a facility which is better equipped. But as we say, that we cannot always be very intelligent. Some of our low risk patients also land up into PPH, and we may not know that. We see that the patient is having a fibroid, or patient is having some coagulopathy. Or patient is taking some drugs. Patient may not have thought of telling their uh, obstetrician that they are taking some drugs for a long time. So all these conditions can occur. And whenever the patient comes into the labor, as we tell, preparedness is very important. IV line, blood cross matching, and close observation of the maternal condition as well as the fetal condition throughout the laboring process is very important. Because during labor, if there's a maternal tachycardia, we should know what is the cause of maternal tachycardia, why the mother is having maternal tachycardia. If there is fetal drop, fetal distress, then also we should think why the fetus is having a low risk mother is having fetal distress during labor. So preparedness, counseling, and quick action and decision. And as Dr. Asha said, that teamwork, because sometimes you alone cannot manage things. Your staff should know that whenever a patient comes, she has to put an IV line. She has to take a blood for cross matching, hemoglobin, PT, APTT. This is a routine with our hospital. As soon as the patient enters the labor room, they put an IV line, they take the blood for CBC, PT, APTT. So we know what platelet count she has, whether her prothrombin time and activated partial thromboplastin time is normal or not. Because if there is any aberration in these readings, then we are prepared. If the patient's platelet count is low, we cross match PRP or we arrange apheresis. So all this acts to the part of the preparedness for the labor patient. So this is how we work, and everybody should know what they have to do. Every time a doctor is not going to tell our staff that take the blood for cross matching, take the blood for CBC, take the blood for PTA, PTT. It should be automatically done. And within 1 hour, the report should be there so that you know where your patient stands and how risky her delivery can be. So this is how things go: counseling, preparedness, activity, teamwork, and quick action. As soon as the patient shows signs of PPH, you are acting. You know where your mesoprost is, you know where there's a prostaglandin kept, and immediately it's taken and given to the patient. And sisters know whom to give, how to give, and this message has to be given 24/7. It should not happen that only the morning staff knows where the drugs are kept. Even the night staff should know where the drugs are there, how to prepare them, how to bring them, and the PPH tray. That is very important. A tray should be dedicated, and everything should be there. This is how we do preparedness, counseling, activity, as well as quick decision making. Then and then only we can save our mothers from the ordeals of PPH.
True, ma'am. And also, I think because childbirth is mostly a very pleasant and an experience that a couple is always looking forward to. And especially in a low risk pregnancy, they're not expecting things to go wrong. So it's important to also explain to them that it is not always a very rosy picture. Things can go wrong, and you have to be prepared, and how we ourselves are trying to get prepared for that, for any untoward complication. Because nowadays patients want to know even if you put them an injection or a drip, they want to know why it is being given, what's the reason for it, why can't we avoid it. And so you need to address all those queries as well. So now, coming to a low resource or a resource constraint setting, ma'am, Dr. Deepa, I'd like to ask you, what kind of challenges are associated with managing a PPH in a resource constraint setting, and what are some of the most effective strategies for addressing these challenges?
Yeah. Asa, this question I feel is almost been answered already by Dr. Asha and Dr. Mala. Most of it we've already discussed. Like have to should be transported. Those transport it is when you're even in a low risk patient, you can always land up into a complication at any point of time. So that preparedness is very, very important at whatever settings you are, whether it's a primary healthcare or it's a secondary or a tertiary healthcare. Being prepared and knowing when you have to go to a higher level is very, very important. So it starts not just with the doctors or the patients, it starts with the fourth class employee, the GDA, the nurse who's helping you. So at every stage, there should be a preparedness for whatever is happening. And of course, we've also talked about antenatal care, where we have already discussed that in a low resource setting, it is important that the antenatal care that the patient is getting should be in such a manner that a hemoglobin is built up. So if you have a good reserve, so anybody can have a PPH, a low risk patient can have a PPH. Counseling or no counseling, it really doesn't help. You can counsel a high risk patient, you can explain to a high risk patient that you might have PPH and we are prepared. But for a low risk patient, you'll never counsel her. You'll not tell her that you can land up into a PPH. She'll be scared to have a baby, right? So it's important for us to be prepared on our own. And if we know we are at a low risk setting, maybe my hospital doesn't have a blood bank, but I know that I have something on a backup where my blood can reach me within 30 minutes, if not 20 minutes in a high risk, in a tertiary setup. So that is very important. I should know when my patient needs to be shifted to a higher center. So that is important. So if I have a patient who's had some amount of bleeding, but I'm noticing some signs that this is a patient who might get into a hemorrhagic shock, I should know that this is the time before she gets into a shock state, she has to be shifted into a setting where she can get all the resources. And with the use of misoprost, which is a drug which can be used without a temperature control system. It's a wonder drug for a low risk setting, wherein just having misoprost next to you, you know your staff is trained, you know your staff can start by manual massage, which can be done, and then misoprost just 1,000 uh, just put into the rectal area, and you've got a response there. And that's a drug which can be available at the most low resource setting also. So it's not just the drug, it is also the preparedness of the staff and the person who's dealing with the patient. Uh, the, the setting wherein you have a contact where you can shift the patient as soon as it is necessary. There might be a primary care health center where the patient has a PPH, but the nurse or the attendant who's handling the patient should know, okay, this patient is bleeding, I need to shift her to the tertiary care hospital as soon as possible. She should have that ambulance and everything ready, at call away, so that the patient can be shifted. Because here, the time that she's spending to decide and to shift is very, very important. So like I said, that most of these things we've already discussed. So putting them together, antenatal care where the hemoglobin level should be good, identifying high risk patients, but having a prepared team to shift the patient when it's necessary, having drugs like misoprost or oxytocin available, if not oxytocin, at least misoprost available, knowing when to identify PPH. So our staff should know, okay, 1,000 is the level where we call it PPH. But anything which is 500 ml in a normal delivery, we have to be prepared that this patient might bleed more and might need to be shifted to a tertiary care center. So again, teamwork, antenatal care, teamwork, all this gets important here.
Thank you, ma'am. And when you talked about misoprost, I was also reminded of when I was doing my senior residency in MAMC. We did a thesis on condom catheter balloon, which works as effectively as Bakri's balloon, and it's really cheap, and that can also be used in low resource settings for balloon tamponade, and it's very effective. We hardly had to do any internal ligations at that time.
Yes, so having that available and then having to shift the patient, because it's not just doing the balloon, it has to be that the patient then has to be shifted to a tertiary care where she can be attended to.
So now coming to a little bit of technology, I'd like to ask Dr. Asha now. Ma'am, so now as we see that technology and innovation has been really playing a role in improving healthcare. So what are some of the most promising areas of research in this field, and how do you think it is helping in prevention, diagnosing, and managing postpartum hemorrhage?
Look, it has come to stay. It is not just because it's this year's theme. You know that it has already been, or it is being used in abnormalities of NST, where there are sudden fetal decelerations. It is helping in diagnosis of preterm labor. Of course, as far as we are concerned in obstetrics and gynecology, it has a lot of role to play in endoscopy, in early diagnosis of cancer of the cervix, early diagnosis of breast cancer. But as I said, that these things are expanding. Technology as a telemedicine, as a telecommunication tool. If you have a doubt, there is nothing preventing you from calling up somebody in a place or in a center where you have, where you can get expert advice. Because today even the data transfer, it's very easy. You can transfer each and every data, and sometimes there are these bots which help you to identify that this is a problem and you can deal with it. So identifying a high risk patient, what is the therapy you're going to give to a high risk patient to prevent a risk, and so many other things. So we belong to a generation which is technologically challenged. But I think today each one of us we are seeing how much of a benefit it is. When that person told me that this NST can automatically tell you that there is a problem with the fetal heart, and as somebody very rightly mentioned, why should there be a problem in a low risk patient or in a patient with no problem? It helps you. There are so many other things which soon we are going to have artificial blood replacement and so many things, which I will not ever now say that it's in the realm of fantasy. Artificial wombs have come. ART has, progressed to mind-boggling levels. So we hope that we can also soon utilize it more and more in our field. Whatever the intelligence, whatever the thing is, nobody can as yet replace you. So we all have a great responsibility to seeing that we update ourselves, we have a team, and definitely use artificial intelligence in whatever way that we can. Ultrasound images today to diagnose a Acrita, Previa, Percrita. It is becoming so much easier with 3D ultrasound. Before, MRI was the only way. Today, 3D ultrasound is replacing so many. You have a retained placenta. You have an AV fistula. After all, where there are placental abnormalities, if there is no obvious cause, look for problems with the blood flow, which is being done so nicely with so many of these newer technologies. So maybe as yet we are just at the tip. The possibilities are numerous and they are absolutely increasing day by day. Where it is going to lead, I don't know. As somebody rightly said, in spite of all our efforts, PPH is one of the leading causes of maternal mortality. It is partly preventable, and that is the reason by whatever technology, whether it is artificial intelligence, whether it is a government help in, as antenatal, giving IV ion made available, everything is adding in helping us to prevent a maternal morbidity and mortality.
True, ma'am. I think I love your answer. So, yes, PPH is here to stay. There is technology to help us, but there's nothing that can replace you. So, that's what I think should be our take home message. So, now my final question to all of you. Uh, your input from on how can healthcare providers and policymakers work together to ensure that women who experience PPH receive compassionate, culturally sensitive, and evidence based care that meets their individual needs and preferences. Dr. Mala, ma'am.
See, basically, nowadays WHO is talking about respectful maternal care. So each and every antenatal and pregnant mother deserves respect, and she deserves a good antenatal care, good care during the intrapartum phase as well as in the second stage of labor and the postpartum phase. So every time she should be nicely monitored, carefully taken care, and best facility, whatever you can provide to her, should be given to her so that pregnancy and childbirth will become a loving experience for her, which lasts lifelong with her. And at the end of it, both the mother as well as the baby should be healthy. That should be our motto.
Thank you, ma'am. Dr. Deepa.
Yeah, I think Dr. Mala has very nicely summed it up for all of us. That at the end of it, we have in obstetrics so many challenges, so many unexpected things happening, and even with all our preparedness, things can go wrong. But it's from our side, it should be the ultimate care that we can give to the patient. And counseling gets important, that you've explained everything to the patient. That's important. Again, your backups are important. So whether it is from the government point of view or from your colleagues or from the health setup where you're working, the support system is very, very important. Postpartum hemorrhage is a obstetric emergency which anybody can face, and the outcomes can be very good or very bad. And to be absolutely prepared for it, for any, even a low risk, the most low risk case is important. And that is where we can deliver healthy babies and healthy mothers.
Thank you, ma'am. Ma'am, last words from Dr. Asha, ma'am.
Everybody has said, and we are all saying the same thing. You have asked about how we can work with the governments. You
With
see,
the government, yeah.
whatever setting you are, they should get the best antenatal care available. By which I mean free medicine should be given. Iron, calcium must be available. They must be able to do all the investigations that are needed, whether it is a TSH, whether it is a hemoglobin electrophoresis to know if they have thalassemia. They must have the facility for an ultrasound examination, if not at the primary center, somewhere which is associated where they don't have to pay a lot. Blood must be free. A lot of the time we had problems in the past because a poor person could not pay to get the blood. Biggest thing that has happened today is if you need blood, no blood bank can tell you unless you replace blood, we will give you blood. Originally it was you replace, then we will give one blood, we will give. PPH requires n amount of blood. So that is where the government has really worked, that blood is free, cap on the cost for your blood bottles, whatever you are getting, and definitely free transport. How are you going to take that woman from one place to the other? You see, when the factors were analyzed, one of the biggest causes of not utilizing was because the woman says, in my village, how do I reach a center? How do I go to the hospital? I'm bleeding, but I have no way of reaching. So see that the transport is there. And most important, identify which center you're going to. Don't make them waffle around so that she has to go from A to B to C to D till she reaches a place who will accept her. When you are leaving from the center where she is being transferred to needs to be aware that they are getting a patient and be prepared that this emergency is coming. And it is important when you are transferring, put that anti-pneumatic shock garment. It is temporary with the ball for temporary aortic compression on and off. It can save a life. So all this is not possible by however fancy our hospital is. It has to be the government with the person taking the advice, with your full system of healthcare providers and the tertiary care hospital. It is possible. It is definitely happening. It is possible. And we hope that more and more women, today most of the deliveries are in an institute. So we expect that along with institutional care, they accept the inverted triangle of the antenatal care and come to us in the second and third month, because giving iron in pregnancy is not enough. They better see to it that the adolescents are taking the iron so that their pregnancies are not complicated and not a problem for them and for all of us to manage. I think all of us have a role to play in that.
True, ma'am. Thank you so much. And I think, as you rightly said, not just us, but the entire policymakers and the government should also, I think, get involved. And I think hopefully with forums like these, we can spread more awareness about a topic like this, and and so that policymakers do take note, and more healthcare facilities, women-centric, are provided to India. So, with this, I'd like to thank all of you. It was wonderful having such an enriching discussion with all of you, and I'm really obliged to be a part of this panel. Thank you so much, Dr. Mala, Dr. Deepa, and Dr. Asha.
Thanks, Astha. You did a great job.
Yeah, I must thank Dr. Ritika and Dr. Astha for a wonderful panel today.
Yes, Dr.
It was
Ritika
a
and
nice
Dr. Astha,
pleasure to be a part of it.
nice panel.
I
Thank
would
you very
like to
much.
thank all the esteemed panelists for taking your busy time from your very busy schedule today, and this discussion has been very informative and has provided a valuable insight into this critical issue. So thank you so much, all the panelists, for this discussion. Thank you. Thank you, Dr. Mala. Thank you, Dr. Rastha. Thank you, Dr. Asha
Thank
and
you.
Dr. Deepa. Thank you so
Thank
much
you.
for your time.
Thank you.